Recording has started.
Good morning. My name is Dr. My name is Dr. Frierson, and I'm the Director of Consultation, Liaison Psychiatry for the University of Louisville. And I'm joined by Dr. Christopher Stewart, who is our addiction medicine specialist. And we're going to talk to you today about the pharmacotherapy of depression. In my role as a consultation psychiatrist, I see a lot of patients in the hospital who have either a psychiatric condition pre-existing or some emotional reaction to their medical problems, or a combination of both. And we see people who have depression and anxiety and dementia and encephalopathy, suicide attempts, and suicidal ideation, and competency evaluations. And we work with neurology a lot. We share a lot of patients, those who have conversion disorders and post-stroke depression, for example. But today we're going to talk about the pharmacotherapy of depression. And we have an ambitious schedule. I was talking to my partner here. I remember the days when we used to use carousel slides to drop them in a carousel. And so if there's some glitches here technically, I'm old school, so just be patient with me. We'll get through it. So this is our outline. We're going to talk about the depressive disorders, the different categories of diagnostic depression, and what treatments you should use for those conditions as well. We'll talk about suicide demographics, and how to evaluate someone after a suicide attempt to decide whether to send them home or not. And then we'll talk about different agents for treating depression. We'll talk about the SSRIs, the SNRIs, and the MAO inhibitors, psychostimulants, mood stabilizers. And we will also discuss at the end some of the newer agents, ketamine and Zulresso, and also some investigational drugs like mushroom, psilocybin. So we have an ambitious schedule. We'll try to get through it in about 45 minutes and leave time for questions at the end. Okay. So the first thing we're going to talk about are the persistent depressive disorders. These are patients who, for most of their life, have been depressed their entire life. In fact, the diagnosis requires you have no more than 2 years of normal mood during that time. They are chronically depressed. We used to call this the dysthymic disorder. They can have a superimposed major depression on top of that, but mainly they're depressed all their lives. And these patients respond very well to a combination of psychotherapy and antidepressant medication. The second category is adjustment disorder with depressed mood. And these patients have a stressor that's occurred in the last 3 months. If that stressor were removed, they would not be depressed. A lot of people in the hospital who have medical illness are in this category as well. And so these patients very often do not need to be on antidepressant medication. The third is depression due to a general medical condition. And we see a lot of patients who have either thyroid disease or post-CVA depression, or small cell lung cancer can all cause depression. And the thyroid patients very often will have a psychosis as part of their depression. We had one lady who we saw in the hospital who had a TSH of 166, and she was psychotic. She was depressed. She thought she was delivering 10 babies every night. Treating these patients requires treating the medical condition first, because they don't respond to antidepressants alone. This lady had to be on IV Synthroid for months for depression to resolve. So depression is often associated with a medical condition, and these are the most common ones you see on your screen. The fourth category is substance-induced mood disorder. These are patients who are depressed and who are also using depressant agents like alcohol or benzodiazepines or barbiturates. It's really important to not treat someone who's still drinking alcohol with an antidepressant. You're fighting the alcohol as a depressant, and the medication doesn't work. So the really important thing is to look at periods of abstinence. So I always ask patients who are still drinking, what's the longest period of clean time that you've had? And during that time, were you more depressed or less depressed as time went on? If when they stop drinking, they get less depressed, and they probably had a substance-induced mood disorder, and they don't require antidepressants. If they still get depressed or more depressed when they stop drinking, they have two conditions, and you would treat those patients with an antidepressant. You can also see depression as part of the abstinence syndrome for drugs who are stimulants like cocaine and amphetamines. So those patients are often will be suicidal when they're coming off these drugs, and they need to be on antidepressants as well. Bipolar depression, there's bipolar 1 and bipolar 2. And the difference is that bipolar 1 need to have at least one lifetime manic episode. And we'll talk about the different medications for treating those conditions a little bit later in the presentation. You can also have major depression with psychosis. And in that condition, it's very important to treat the psychosis first or treat them both simultaneously. You don't want to treat the depression alone because that may lead to activation and the patient may begin to act on the voices they're hearing, telling them to kill themselves. So always treat the psychosis first and then the depression later. And these patients are very depressed. They can progress to catatonia. If they do, you may need to use lorazepam for treating the catatonia or even ECT. The next category is postpartum depression. And it's very important to differentiate this from the postpartum blues you see, or after delivery. That's a hormonal change. Postpartum depression occurs later, about 4 to 6 weeks after delivery. And usually what happens is the patient delivers the baby and everybody's around the baby at the time of delivery and everybody's helping her out with the baby. And then after, when everybody leaves and goes back to their own lives, it sets in that you now have a new responsibility. And so that's when you see the depression, 4 to 6 weeks after delivery. It is much higher in patients who already had it before. So I always ask about a pre-existing postpartum depression after previous deliveries. That's important to do. It can also progress to psychosis and even some infanticidal behavior and suicidal behavior. Women have killed their children as part of this condition. So it is pretty serious. So if we have someone who's had postpartum depression before, we will treat them empirically for depression even before they show the signs of it to avoid occurring this again, because it takes about 4 weeks to 6 weeks for the antidepressants to work. So treating them early is important. And Zulresso is a new drug that's FDA approved for treating postpartum depression. And we'll talk about that a little later, but it is a drug that's used IV right after delivery. And this can help prevent postpartum depression. The next category is depressive pseudodementia. And occasionally we see people in the hospital who look demented, who come in with mental status changes consistent with dementia, memory loss, but they actually are depressed. And it's really important to be able to tell the difference, because usually what happens, the dementia workup is negative. They have a normal MRI or CT or other workup, but they do have vegetative signs of depression, sleep and appetite changes, energy changes, poor concentration. People who are demented from depression will have I don't know answers. You ask them what date it is, they'll say I don't know. They have some insight. People who are true demented will guess. They'll tell you in a minute that it's 1929 and argue with you. You say it's 2020. So the hallmark of a depressive pseudodementia are I don't know answers. The hallmark of a true dementia is guesswork. One of the things that we do to try to tell the difference is to give a psychostimulant challenge to the patient. If you give a patient who has a depressive pseudodementia Ritalin, for example, after 3 or 4 days, their mood will improve and so will the cognition. If they have a true dementia, they'll get more confused after the Ritalin. So that can be a way to differentiate between a pseudodementia from depression and a true dementia. The next category are seasonal affective disorders. If you think about how this time of year the days are shorter, it's dark when you go to work or dark when you come home, and everybody gets depressed about that. Well, just imagine people who have every year with fall and winter get more depressed. These patients we often would treat during those times with antidepressants, but they also respond to things like tanning boosts, ultraviolet light, and light boxes that can be bought even on Amazon. So that's the seasonal affective disorder. The next category we're going to talk about is depression and bereavement. So very often depression is a common feature in normal grief. This depression may involve passive thoughts of death. The patient will say to you, sometimes I don't care if I wake up, I want to go and join the person who died. They're not actively suicidal, but they wouldn't care if they didn't live any longer. So that's a pretty common feature in depression and bereavement. Sometimes it can involve a suicide pact. Oftentimes, family people will decide they're going to kill themselves when the person who has a terminal illness dies. We saw that a lot with the AIDS epidemic and partners who would kill themselves when the person died. It's very important to determine during family-oriented holidays like Thanksgiving and Christmas, you see more of this depression. because they're reminders of the times they were together when the patient was alive. Increased risk of complicated bereavement. It's very important when the patient who's grieving to go through the rituals of grieving, to go to the wake, to go to the funeral. If you don't do that, you're more likely to have a complicated grieving. We had one lady who did not go to the funeral of her mother, and she believed her mother didn't really die. And she actually went and tried to dig up her mother's grave. On a number of occasions, they had to ban her from the cemetery. So it's really important to go through the rituals of grieving. The funeral is for the living, not for the deceased. If you don't do that, complicated bereavement is often the result from that. So we like to avoid treating bereavement with medications if we can. So avoid antidepressants, avoid long-term sleep aid use, avoid anxiolytics, because that will only protract the grief. The best treatment for grief and depression is the passage of time. So just be patient. Very often a religious counselor or a pastoral counselor can be very helpful as far as helping the patient adjust to the depression associated with bereavement. So in general, depression with bereavement does not have suicidal ideation, but it may have passive thoughts of suicide. It's accentuated on anniversaries, the patient's birthday or anniversary of the marriage, and there is complicated risk of bereavement if the patient does not engage in the rituals of grieving. So let's talk about major depression. These are the symptoms of major depression. There's usually a sleep disturbance, and it's important to differentiate the sleep disturbance in major depression. It's usually early morning awakening. They can fall asleep, but they wake up in the morning at 2 or 3 in the morning and cannot fall back asleep. Whereas people with anxiety have a long sleep latency, they cannot fall asleep. So the sleep disturbance in major depression, early morning awakening, they have fatigue, they have very poor concentration, they have anhedonia, or they have psychomotor agitation or retardation, hopelessness and guilt, a depressed mood. They either have suicidal ideation or even dreams of death or nightmares about dying. They have appetite changes, either anorexia or hyperphagia, usually the anorexia. So to make this diagnosis, you need at least 2-week duration of symptoms, and it has to be 5 of the 9 above features I mentioned, and 1 of the 5 has to be a depressed mood or anhedonia, and that's the diagnosis of major depression. Now, if we look at demographics for this country as far as who kills themselves, the number 1 group are the Alaskan Eskimos. That's number 1. And we believe that because you may have 4 or 5 months of darkness in that condition, they have a strong seasonal component as well. Native Americans are second. The third are elderly white males, especially those who are divorced or retired or widowed. Then white females, younger white males, and younger African American males. We did a study years ago of about 300 people who tried to kill themselves, and people who are in the age group of 20 to 40 years old, for every successful suicide, for every 100 attempts, you have 1 successful suicide. If you're older than that, in the 80 age group, it's 1-to-1. So there are no jesters in the older age group. We very seldom see people in the hospital who are 80 or over who survive a suicide attempt. They tend to die from those attempts. And these are the reasons. Generally, older people have more irreversible reasons for trying to kill themselves. Things are not going to get any better. Chronic pain, widowhood, chronic medical conditions. They usually have access to large amounts of medication. They usually have coexistent medical conditions like liver disease or renal disease are going to make them less likely to survive the attempt. And unfortunately, they're often living alone. So sometimes they may be dead for days before anybody finds them. It's even worse during the pandemic because of more of the social isolation. So again, living alone and not having someone check on them is a reason for a lot of older patients to not survive suicide attempts. This next slide talks about victim-provoked suicide, and there are some patients who want to die but do not want to kill themselves. So they will often put themselves in situations where they are likely to be killed by others. They provoke their own death. Usually feelings of hopelessness are part of that as well. And the official cause of death may be listed as a homicide, but actually it's a suicide. We see this a lot in young males especially, which may be a reason that young males are so low as far as the demographic of suicide because they're misdiagnosed because of homicide. So we should call this suicide by cop. You see that a lot in younger populations. So what are deterrents to suicide? It's very important to ask the patient who has suicidal ideation, why they have not actually tried the attempt. And the number one is religious faith. Most religions believe that if you kill yourself, you're going to go to hell. You're not going to see people that have already died. You're not going to be united with them. And so patients very often, their reason for not killing themselves is religious faith. So I always ask about religious ideation. Caregiver roles, so they can take care of the children or an elderly parent. They want to be alive to do that as well. And a lot of patients feel that if they survive the attempt, they'll have some long-term consequence, disability. And so they're afraid to attempt because it may be unsuccessful and they have some major body image change to deal with. So these are the most common deterrents to suicide, but without question, the most important one to ask about is religious faith. So we see hundreds of suicide attempts every year, and we cannot admit everybody who tries to kill themselves. So we have a criteria that we use to decide who goes home and who goes to the psychiatric unit. And these are the 11 criteria we use to decide that. The first is premeditation. Did the patient buy a gun? Did they buy bullets? Did they load the gun? Did they leave a suicide note? Did they pick out their funeral clothing? Did they make sure they would be alone so no one would see them or find them? Did they leave a suicide note? These are all important questions to ask if they indicate premeditation, and that can be a pretty serious. If there is premeditation, they're more likely to be admitted to the hospital. As opposed to someone who just had an argument with a spouse and then took pills in front of the spouse, more impulsive behavior, they may be able to be sent home. Intent. What did the patient want to happen when they took the overdose or made the suicide attempt? If they did something that we know would not have killed them, but they thought it would, that's pretty serious intent. I remember years ago, we used to have people that were going into stores and picking up bottles of Tylenol capsules. They were putting cyanide in those capsules and putting them back on the shelves. And we had a patient who came in the hospital who went to the store, took two Tylenol pills as an overdose. And people didn't take her seriously. She said that she thought she'd get a bottle that had cyanide in it and it would kill her. And so from her standpoint, this intent was pretty serious, even though we knew this would probably not kill her. So it's not about what you think might kill the patient, what they thought would happen. What did you want to happen when you did this? If they wanted to die, that's pretty serious intent. And those patients are usually kept in the hospital. A pre-existing major depression is also a reason to keep somebody in the hospital. Command hallucinations, hearing voices telling you to kill yourself or kill somebody else. If there is associated alcohol or drug use, we feel better about those patients. Somebody who does something stone cold sober is probably more serious than someone who was under the influence of alcohol. And very often people who are drinking at the time of an attempt will not be suicidal once they sober up. So it's really important to differentiate that as well. Did they do anything to save themselves? A very important question to ask these patients. Did they call 911? Did they tell someone what they had done, or were they found just by accident? So if they tried to affect their own rescue, that's a good sign, and we may send that patient home as well because they may have changed their mind about wanting to die. If they were found without any kind of intervention on their own part, those ones might stay in the hospital as well. What was the method? And we've seen many different methods. People who jump off bridges, jump off buildings, people who set themselves on fire, people who try to hang themselves, people who will cut their wrists and get in a warm tub of water so that their veins will dilate so they're more likely to bleed out. I've had to go a couple of times down to the bridge to talk people down off the bridge. It's a very dramatic event. There usually are paramedics there and firemen there and the police are there and the patient may be halfway up the bridge when you get there. You have a big megaphone asking the patient to come down. The family often comes down. These patients very often will come by. They will walk by the bridge many times when they try to kill themselves. They will try to determine when traffic is at the lightest so no one will find them. So this is a strong premeditation associated with this condition. People who survived bridge jumping and building jumping and hanging they usually survive by accident. The rope broke. Someone found them in time. The gun misfired. So if they're alive, it's not because they want to be, basically. So the method is a really important criteria as far as deciding who's going to stay in the hospital psychiatric and who's going to go home. Has anything changed the result of what they did, basically? Change the precipitants. If they have financial problems and they tried to kill themselves, now they have a hospital bill, so the reasons are worse. If they had a problem with a relationship with somebody that's come back to talk to them and they're more supportive now, it may be better. So has anything changed as a result of the attempt? That's part of the evaluation after a suicide attempt to decide whether to send them home or not. What is their support network? Do they have someone they can rely on? Do they use that support network? Any previous attempts? And of course, the last one, current feelings about being alive. So these are the 11 criteria that we use to decide whether to admit someone or to send them home. And the most important ones are premeditation, the intent, the method, and how they feel about being alive at this point in time. So how do you decide which antidepressant to use? This slide summarizes that. The side effect profile is really important. If somebody is obese, you might not want to choose a drug that's going to cause weight gain, for instance. Um, if they have depression with anxiety, you might want to use a different drug that's going to cause an anxiolytic as well. If you have somebody who has sleep and appetite disturbance, you're going to use a drug that may be more sedating. Uh, you don't want to give a drug that's going to have some adverse effect on other conditions like their heart disease or lung disease or renal disease. Um, Cost is very important. You want to use a drug they're going to be able to afford. If you have a right drug you want to use, but the patient can't afford it, they're not going to take it. So it's really important to consider cost when you decide about an antidepressant to use. In addition, there's also a genetic component. So if someone in their family responds to a certain drug, they may respond as well. So it's really important to ask about other patients in the family, people in the family, parents especially who've had a response to a different medication, and choose that drug first because the patient may respond to that as well. So this is how you select an initial antidepressant. And these are the classes of antidepressants we're going to talk about today. The SSRIs, the SNRIs, the Tricyclics, monoamine oxidase inhibitors, the Psychostimulants, mood stabilizers, and atypical drugs. The most common drugs that are used to treat depression are the SSRIs. These are drugs that's reuptake of serotonin, and the reason for that is they're very safe in overdose. They have a very good side effect profile. They are usually weight neutral, and they also can treat other conditions like OCD and PTSD and panic disorder. So they are the most popular drugs for treating depression at this point in time. They do have some side effects, of course. The sexual side effects are fairly common. If they do have those side effects, you either change the drug or you can add Wellbutrin, which is bupropion, which will help with sexual side effects. They do cause SIADA, so hyponatremias are really concerned with these drugs. If the patient does have low sodium, they should not be given an SSRI. They can also have an antiplatelet effect, so they can increase bleeding. So people that are on anticoagulants, people that have a history of ulcer disease, these are not the best choice for them as well. And so we usually will hold the drug a day before surgery to try to avoid excess bleeding after surgery, just because of the bleeding risk. They do cause QTc prolongation, so there's a risk of torsades with some of these drugs, especially Paxil and Prozac. There are many drug interactions as well. And like all antidepressants, they can increase the suicidal thoughts among teenagers and young adults. So whenever you give an antidepressant to any teenager, you always let them know if they do have increased suicidal ideation, suicidal thoughts, the drug should be stopped. And these are some of the side effects of SSRIs. The mild side effects, serotonin excess, you can get mild flushing, sweating, restlessness. That's not usually a concern. But the serotonin syndrome is when you have more serious side effects. And they include, if you have a combination of one or more serotonin drugs, you can have these effects. They have adrenergic hyperactivity, so they have blood pressure and pulse elevation. They often have clonus and myoclonus and other movement disorders. It looks very similar to NMS when you see it clinically. And it can occur with non-psychiatric drugs like tramadol and Imitrex and linazolid can all combine to cause serotonin syndrome. So the treatment for this condition is to stop the drug, obviously, supportive care, and add a serotonin antagonist like cyproheptadine, which is an antihistamine that's used for treating serotonin syndrome. If you have a patient who's on a serotonin drug and you stop it without tapering it, you can get a serotonin abstinence syndrome. And that includes anxiety, sleep disturbance, and confusion. It really is important to taper these drugs, especially a drug like paroxetine, which has a very short half-life. So these serotonin excess can cause some mild symptoms. Serotonin syndrome is very serious. People can die from that, so it's really important to avoid that if you can. And the serotonin abstinence syndromes come when people stop serotonin drugs precipitously without tapering them. And these are the SSRIs. Fluoxetine is Prozac, and the dose range is 20 to 80 milligrams. It's given as a one-time-a-day dose. It should be given in the morning. It's more of a stimulant, so it should not be given at bedtime. It can have some anorexia properties as well. Sertraline is Zoloft, and the dose range is 25 to 200 milligrams a day. It's also a once daily morning dose. Citalopram is Celexa, and the dose is 10 to 20 milligrams a day, once in the morning. Escitalopram is Lexapro, and the dose is 5 to 30 milligrams daily. Trintellix, 5 to 20 milligrams a day, also in the morning. And Paxil, 10 to 60 milligrams a day. Luvox, 50 to 300 milligrams daily, and Vibrit, 20 to 40 milligrams a day. We'll talk about these drugs individually as well. In general, most of the antidepressants can be given once a day. They last for 24 hours. Let's talk about Prozac. It's the oldest of the antidepressants, of the SSRI antidepressants. It is very activating, so it should be given once in the morning. Has a very long half-life, so there's no need to taper this drug. If you take Prozac, you stay in your system for a month or 6 weeks, so it's really important you can just discontinue this drug without tapering it. It's very anticholinergic, so it causes symptoms like mydriasis, urinary retention, constipation. So it can also increase confusion in the elderly patient as well. So that's a concern about Prozac. It has a lot of drug interactions, especially with drugs like warfarin or digitalis. We had one patient who was on Prozac and Coumadin and an INR of 15 and had a brain bleed because of that. So it's really important not to use Prozac or Paxil with warfarin or digitalis. You can use it with Eliquis or other anticoagulants, but not with these agents. So more drug interaction with Prozac than you see with any of the other SSRIs. It does have a very, very delayed onset of action, so it takes about 6 to 8 weeks for Prozac benefits to show up. You may see something early on, but that's not the full effect. That's usually endorphin related, and QTC prolongation is a possibility with Prozac as well. So with Prozac, a lot of drug interactions, a very long half-life, no need to taper it, some cardiac condition with QTC prolongation, and it's very anticholinergic. Paxil, paroxetine, has the shortest half-life of all the SSRIs. That's why you have to taper this drug. So you have a pretty serious withdrawal syndrome if you don't. It also is very anticholinergic, has similar drug interaction profile as Prozac we talked about with Coumadin and digitalis. It does cause heart disease in pregnancy, so this is the one SSRI you should not use during pregnancy. It causes VSD. But because of its short half-life, it is safe for breastfeeding. So for breastfeeding, the safest drugs are Zoloft and Paxil. So sertraline Zoloft, the most commonly prescribed SSRI, is less anticholinergic. It has fewer drug-drug interactions. It is a treatment of choice for pregnancy, and safe for breastfeeding. Fluvoxamine, Luvox, is very useful for treating OCD. It's approved for OCD. And the citalopram, Celexa, is a drug that it's the SSRI that has the most serious cardiac effects. So it should not be used in older patients, people with heart disease, because it is the drug most likely to prolong the QTC. You consider using Lexapro instead, which is a similar drug to Celexa, which has very fewer side effects. So avoid doses of greater than 20 milligrams of Celexa. You see somebody on 30 or 40, that's too much, especially for older patients, because there is a risk of heart disease with this drug. So Zoloft, the most commonly prescribed antidepressant, safe for breastfeeding, safe in pregnancy, very few drug interactions. Luvox, used for treating OCD symptoms, very effective for that. Celexa, most cardiac effects, avoid that in patients who are older or who have some kind of heart condition. The next slide are on the SNRIs. These are drugs that inhibit the reuptake of norepinephrine and serotonin. Very often they can increase anxiety because they have a stimulant effect as well. Venlafaxine or Effexor is a drug that treats depression and anxiety, so that's a drug in this category. They are more activating. They can also cause hyponatremia and bleeding issues like the SSRIs can, but they have fewer drug interactions than Prozac or Paxil. They can increase blood pressure, so you want to avoid these drugs in patients who have a significant history of hypertension, and they can be lethal in overdose, many from the serotonin syndrome. And the three most common ones are listed here. Duloxetine, dose range is 30 to 120 milligrams a day. Venlafaxine, 37.5 to 225 milligrams a day. And Pristiq, 50 to 100 milligrams a day. These are the three most commonly used SNRIs. So unlike the SSRIs, these drugs have norepinephrine activity as well. They are more activating. They can raise pulse and blood pressure. They have fewer drug interactions. but they can cause serotonin syndrome as well. So the first one we'll talk about is duloxetine or Cymbalta. This is a drug that treats depression and chronic pain. So patients that have chronic pain from diabetic neuropathy or HIV neuropathy um, do well with Cymbalta. It should not be used in patients who have renal failure or hepatic failure. It does lower the seizure threshold. The chronic pain dose is a little bit higher than the antidepressant dose. It can go up to 120 milligrams a day. And so it's a good drug to use in a combination of patients who have chronic pain and depression, and we use that drug a lot. Venlafaxine or Effexor, again, as I mentioned before, it helps to treat anxiety as well. And you do want to avoid this drug in people who have hypertension. The next category are the TCAs, and these are drugs we hardly ever use anymore because they have a very high incidence of death with suicide. Usually, if the dose is fatal, is about 1.5 grams, and that's very close to the therapeutic dose as well. So if these drugs are used at all nowadays, they're used to treat chronic pain, especially migraines, and also as sleep aids as well. So amitriptyline, the dose range is listed there on your slide. Again, it's used a lot for treating migraines for sleep induction. Doxepin or Sinequan is also used for sleep induction as well, and those dose ranges there. And Pamelor or nortriptyline is also used for sleep induction. So again, these drugs are very seldom used for treating depression alone. They're usually used for treating pain and sleep. So they're useful adjuncts in the management of chronic pain and migraines and for sleep disorders. But there are many disadvantages to these drugs. They are very highly anticholinergic. The lethal dose is very close to the therapeutic dose. They do have cardiac, especially tachyarrhythmias. They can cause VTAC and atrial fibrillation and death and QTc prolongation. They do lower the seizure threshold, and they have a lot of anticholinergic effects, constipation, ileus, urinary retention. You want to avoid these drugs when somebody has prostate disease or BPH. They cause mydriasis. You want to avoid them with patients who have glaucoma as well. And they can increase confusion, especially in the elderly and delirious patients. So as I mentioned before, they are seldom used today for depression and only for pain management and sleep induction. These are the TCAs. Monoamine oxidase inhibitors. These are drugs that block the effects of enzymes, MAOIs, that break down neurotransmitters such as dopamine and norepinephrine and serotonin. They are not usually the first line drugs for depression because there are some restrictions, but they are very effective when other antidepressants fail. They can be used in pregnancy safely. There's a 2-week window between use of this drug and another antidepressant. If you have somebody on other antidepressant, you have to wait 2 weeks before you start an MAO inhibitor, and the same way to reverse. You stop the MAO inhibitor and wait 2 weeks before you start another antidepressant. The most common side effect of the MAOIs is hypotension, but the most serious side effect is hypertensive crisis, and that can be fatal as well. So you want to avoid tyramine-containing foods like cured meats and aged cheeses and red wine, and some drugs like Demerol and Parodine and cocaine can also cause a reaction as well. Because of the dietary restrictions, people are often reluctant to take these medications, but they are very effective. They do have some drug-drug interactions, and the drugs are listed on your handout there. Phenylcyprine is parnate, very amphetamine-like, very stimulating, and the dose range is there. Phenelzine is Nardil, Marplan, Selegiline, and linezolid. Linezolid is often used for treating the infections in the hospital, and methylene blue. So these drugs are not used anymore for depression unless the other drugs have failed. They do have restrictions as far as medications and dietary restrictions, but they are very effective at treating depression and also anxiety disorders as well. The atypical antidepressants, the one we use most often is Wellbutrin. You may have heard of bupropion. It's a very stimulant drug. It can be used to treat conditions like ADD and ADHD as well if you don't want to use a more addicting drug like Adderall or Vyvanse. Norepinephrine and dopamine reuptake inhibition is part of this drug's profile. It's very good for patients who are very drowsy, sleep all the time, psychomotor retardation. It is activating for those patients as well. It does treat ADHD and ADD. It does treat narcolepsy. If you don't want to use Provigil or similar agents for that, it does treat narcolepsy as well. It can decrease the craving for nicotine. Very often they're used to treat people who have COPD, who are chronic smokers. Adding Robution can help them as far as decreasing the craving for nicotine. It does not prolong the QTC, but can increase heart rate because it is a stimulant. So you have to worry about patients who have either a atrial fibrillation or some kind of tachyarrhythmia. They should not be given Robution. So very low incidence of sexual side effects. It's often used as an antidepressant booster. If someone is on a medication like an SSRI and SNRI and they're not responding to it, and you don't want to go and change the whole medication, you can add Robution to that drug, and it will boost the antidepressant effects. So it's often added to drugs like Zoloft and Paxil and Prozac to boost their effects. Because it's a stimulant, it can increase anxiety symptoms, but is the antidepressant least likely to cause mania in a bipolar patient? If you have somebody you want to treat with an antidepressant who you think may be bipolar, you're not really sure, the safest choice is Robution because it's less likely to cause a manic episode than some of the other drugs. But it does lower the seizure threshold in patients. That's the most common, most serious side effects. You want to avoid it in patients who have a personal or family history of seizures, have a history of eating disorders, who have a history of TBA or recent TBI, or recent CBA, and in those who are in early alcohol or benzoate withdrawal, because these patients are at risk for seizures, and the Robution can lower the seizure threshold. Because it is a stimulant, it can also be anorexiant, and there is some abuse potential, especially with patients who have an addiction history, especially an addiction history to methamphetamine. Mirtazapine is Remeron. It's a drug that we often use in patients who are not eating, anorexic, who are not sleeping. It does increase appetite, increases weight, and also is very sedating, especially at lower dosages. The dose is 7.5 milligrams to 45 milligrams a day. We have serotonin and norepinephrine activity, more sedating at the lower dosages. So if we start them on 15 milligrams and they don't sleep, we'll actually lower the dose, and they may sleep with that lower dose. The higher doses are more for the depression and for the appetite. You want to avoid in patients with a high BMI, obviously, or high A1C, because you don't want to cause those patients to gain weight. It has an anti-nauseant effect as well. So we use Remeron a lot in hospitalized patients who are, again, not sleeping and not eating. Like most antidepressants, it does take about 4 to 6 weeks to have an effect, but it is very effective as far as treating those patients. Trazodone or Desarel is a drug that is used primarily for sleep. The dose range is 50 to 300 milligrams a day. It does have serotonin activity, so it can cause serotonin syndrome when it interacts with other SSRIs or SNRIs. The antidepressant dose of this drug is 300 milligrams or higher, so that drug is often not tolerated because of sedating effects, and so we hardly ever use this drug alone to treat depression. It's usually an adjunct, adding it to Prozac or Paxil or Zoloft for sleep induction at lower dosages. Most common side effect of this drug, obviously, is oversedation, but it can cause tachyarrhythmias. It can cause QTC prolongation as well, and it can cause priapism, which is probably the most famous side effect of this drug. It's very important to tell. Priapism is an erection that lasts longer than 4 hours. Very often, treating that, you can use ice packs initially or a decongestant like Sudafed. You may have to use intracavitous neosynephrine, which is extremely painful, obviously. You may have to go to surgical intervention. So avoid using drugs like Cialis and Viagra with Trazodone because they will increase the risk of priapism. So mirtazapine used a lot of people who are not sleeping, not eating, a good drug for that, does decrease nausea, doesn't have the interaction as far as medication interaction that Prozac and Paxil do, and Trazodone more for sedation, more for sleep, can cause priapism and can prolong the QTC and also cause tachyarrhythmias. These are the atypical antidepressants. We can also treat depression with mood stabilizers. And the first I want to talk about is lithium carbonate. We use it a lot for bipolar depression. The dose is 300 milligrams to 900 milligrams a day. And you want to keep the level between 0.7 and 0.8. Used for bipolar depression, it does definitely, the benefit of this drug, it does decrease suicidal ideation. And that's a very important part of this drug. Most common side effects are weight gain, especially fluid weight gain, intractable diarrhea, and arresting tremor. If you do have a tremor from this drug and they're doing well on the drug, you might want to add a beta blocker. The major cardiac effect of lithium is bradycardia, so it can cause bradycardia. It can also cause leukocytosis as well. But it's an ancient drug, it's an old drug, and it's used a lot to treat people who have bipolar depression, but there are some concerns about side effects. The drawbacks, it does require periodic blood level determination, and some patients will not comply with that. You have to check, and it's important to check levels, especially during times During the summer, people sweat more. Any loss of fluid, sweating, diarrhea, vomiting, will increase the risk for lithium toxicity. It's really important to keep that in mind. Cannot be used in the first trimester of pregnancy. It does cause Epstein's anomaly, which is a tricuspid valve disease. It can be used later in pregnancy, but you should decrease the dose close to delivery because of the fluid exchange, and the patient more likely to get lithium toxic if you don't do that. So, it can cause hypothyroidism, either a euthyroid or hypothyroid goiter. If they're doing well on lithium, you would just add Synthroid. You wouldn't stop the lithium because of that. It does have drug interactions. You want to avoid NSAIDs and thiazide diuretics if patients on lithium. It can cause hyponatremia as well. And it can cause renal disease. It can cause nephrogenic diabetes insipidus. And we had a patient who just recently had a sodium of 180 because of being on a combination of lithium. And that patient had to be off the lithium. They could not take it for the rest of their life because of that. Those patients have to be treated with a synthetic ADH, desmopressin, or vasopressin for that. So that's a pretty serious renal condition that you have to avoid these patients on lithium. They are very highly lethal in overdose. Even though patients who have less suicidal ideation on lithium, if they do try to kill themselves, the potential for dying is much higher than some of the other medications. If their level is above 3 or above, they have to be dialyzed as well. So many benefits of lithium. It is an older drug. It does treat bipolar depression. It does decrease suicidal ideation. It does have some side effects that are manageable: the weight gain, the tremor, and the diarrhea. But it does have some drawbacks. The cardiac effect as far as first trimester pregnancy, hypothyroidism, hyponatremia, and of course the serious renal disease. Lorazepam is Latuda. It is a drug treatment of choice for depression, bipolar depression in pregnancy. It's a category B drug, unlike most psychiatric drugs are category C. The dose listed here. It is an atypical antipsychotic, so it does have a metabolic profile side effect. So you have to worry about things like hyperlipidemia, exacerbating diabetes, or even causing diabetes, pancreatitis. You have to worry about other side effects of neuroleptics like tardive dyskinesia after long-term use, and NMS. It's much more effective for bipolar depression than bipolar mania. And it usually is occasionally can be added on, like as we mentioned before, with Wellbutrin to an antidepressant to treat a resistant depression. So if somebody's on Zoloft or Paxil or Prozac not responding, you might want to add Latuda as a booster to that drug, and it can help. It's weight neutral, and it's a category B drug, so it's safe in pregnancy. So Latuda is often added on to treat depression. Is the drug treatment of choice for bipolar depression in pregnancy. Has a good side effect profile, does not cause weight gain generally, but it's not as effective for bipolar mania as it is for bipolar depression. Lamotrigine, Lamictal, which we use a lot in psychiatry for treating treatment-resistant depression and bipolar depression. The dose rate is listed there. We are very careful with it because of the risk of Stevens-Johnson syndrome, so we will start the patient generally on 25 milligrams for 2 weeks, and then go to 50 milligrams for 2 weeks, and then go increase it back 50 milligrams a dose after that, up to 300 milligrams a day. So we're very careful with that. But it's very effective for bipolar depression. You can often add it as a booster to antidepressants as well. It does boost antidepressants, so we often will add that again, like Wellbutrin and Latuda will add it to other antidepressants to boost them if the patient is not responding. It's the second choice behind Latuda for bipolar depression in pregnancy, and there is concern obviously about Stevens-Johnson syndrome, so slow titration is really important. And obviously, if you want to use Depakote along with Lamictal, you have to adjust the dose of Lamictal. A much lower dose if you use with Depakote, a much higher dose if you use with carbamazepine or Tegretol. If the patient is off the drug for longer than 5 days, we usually go back and retitrate the drug. So you don't want to start the previous dose. So you go back to 25 milligrams and gradually get them back to the previous dose. And obviously, you want to consider this a treatment option for people who have resistant unipolar depression. We've had very good success with adding Lamictal to other antidepressants, and we use it a lot in psychiatry. The psychostimulants, these are drugs like methylphenidate, which is Ritalin, dextroamphetamine. The benefit of these drugs, they have a much faster onset of action than other antidepressants, 3 to 5 days often. You have a patient who is older, who has a terminal illness, who's dying, who's very depressed, and you'll have time to wait long enough for the other antidepressants to work. We use Ritalin a lot in those patients, and they respond pretty well to it. So it's used for medically ill, psychomotor retarded, elderly patients who might not live long enough for other antidepressants to become effective. Usually it does not cause much anorexia at the lower doses that we use for patients. It can cause increased heart rate and blood pressure, so that's a concern as well. As I mentioned before, we often use this drug as a test dose to differentiate between dementia and pseudodementia as well. So psychostimulants, older patients who are extremely depressed, medically ill, again, who might not live long enough for the antidepressants to work, 3 to 5 days duration, not anorexic in lower doses, and very well tolerated. And these patients do pretty well with that psychostimulant. And these are the drugs that we use to augment antidepressants. We mentioned most of these already: Wellbutrin, Abilify, Aripiprazole, lithium, Lamictal, T3, olanzapine, TCAs at lower dose, quetiapine or Seroquel, and mirtazapine. My partner, Dr. Stewart, will talk to you about some of the newer agents like ketamine. I'll give him the podium right now.
Sure. Thanks, Dr. Frierson. Okay. Well, in the interest of time, we'll get busy. We're almost at the end, and so then we'll leave some time for some questions. So ketamine is a newer, old treatment, as we say in the slide here. Here's an example. Here's two formulations of ketamine: the IV ketamine, which has been around for a much longer time, used as an anesthetic, and began to be used with patients off-label with really good anecdotal success, and became eventually formulated into a nasal spray that is FDA approved for the treatment of treatment-resistant depression. We should say that treatment-resistant depression is not an official diagnosis in the DSM-5, but it's certainly something that is talked about a lot, and there's definitely a concept of this that there's a consensus about, and there's no doubt that ketamine is an effective treatment for patients who have failed other treatments, particularly patients with very, very chronic suicidal thoughts, and it works rapidly when it works. There's questions about, is the IV version still better than the nasal spray? To get IV ketamine, you have to go somewhere where they can do an IV. You have to have somebody who can monitor that patient, typically somebody who's at least an anesthesiologist or somebody who has that capacity, or a nurse. You don't have to have the same level of treatment to give the nasal spray, and that was the idea. I'll go on to the slide. I'll go on there. There we go. So the nasal spray, the idea behind that was to make it more available, more accessible for us to be used in the outpatient setting. The brand name is called Spravato, and it's an enantiomer of ketamine. So ketamine, obviously, like other compounds, is a racemic compound. You can have the R and N. It's the S enantiomer, and that's the nasal spray. You can give one, and the patient can actually administer that themselves. It may be not as effective as the IV drug, but you'll see different things about that when you read it, when you read the literature on that. It can last, and eventually you can do maintenance therapy for ketamine, which is, in the beginning you have more often you dose, but then at some point maintenance can be every month to every couple of weeks, depending on the patient's state. Obviously, it's a drug of abuse and has been abused, and that's one of the black box warnings on using ketamine. It is extremely expensive, even when it's covered by insurance. We've tried really many ways to get it started in our clinic. We have not been able to establish it as a treatment here at ULP Psychiatry Clinic. We do work with a couple of clinics in town who have been doing the IV ketamine and now are using the nasal spray. And the patients who have been referred to that have done real well with this treatment. So if there will be questions, we'll come back to that. Dr. Frierson, you were going to talk about Zulresso. So Dr. Frierson had mentioned this treatment for postpartum depression and giving it to patients to prevent postpartum depression. This is not something that I have used. It's extremely expensive. But has fast onset of action. It's a novel mechanism. It's called Zulresso. It's something you might see or encounter or may have encountered already. It's again a newer agent. in postpartum depression, a special kind of depression, really. And I wanted to mention briefly psilocybin, which is something we're excited about, but still it's early. There's definitely bias in the research that's positive in favor of psilocybin, but it does represent also an old new mechanism for the treatment of depression, and seems to be pretty impressive so far in helping people deal particularly with end of life anxiety. People who are terminally ill and suffering from very intractable anxiety will benefit from psilocybin. The question is around dose, and we still don't have an FDA approved obviously mode of this, but you will hear a lot of in this community too, in Louisville. It is being used. It is being given by not just drug dealers or on the illicit market, but by people who are healthcare practitioners in the alternative community here in Louisville. And so there are people who are doing this already in Kentucky, and so we may have people who are on it, who are microdosing it because of their belief that it's beneficial. Psilocybin is basically, the compound is an analog for serotonin. So when it is taken, it works on the just like the molecule serotonin would. We also see that we think that when people take psilocybin, one of the reasons that it works is it reduces threat perception in the amygdala. It helps decrease connectivity in the default mode network, which makes people less vigilant. And we think it affects the activity in the I'm losing all my thought here, on the medial cortex, which is reducing hyperactivity in the medial cortex. Frontal medial cortex is thought to help, some reason why it helps in depression. And I included this slide here, but this is just one organization that's doing research, that has done probably research the longest on psychedelics and mental health, and they're called the MAPS. And they did have I mentioned them particularly, had a conference because they are very interested in increasing access of psychedelics to marginalized communities, and they are particularly interested in the West End of Louisville and increasing the access when it becomes approved for ecstasy-assisted psychotherapy, which it will be an FDA-approved treatment for in PTSD. And so, of course, they have a lot of research that supports, obviously, the things that we're talking about with psilocybin. I just listed some of the other supported research from MAPS for anybody who's interested in that. If you want to ask questions, we can. It's a very broad idea, list of topics. And finally, we wanted to mention, this is the National Suicide Prevention Lifeline. This is a number that patients can be given, and they can call, and there will be someone there. And it's a national funded initiative that, again, helps people and supports people who need to talk, and it's been shown to be effective way of reducing suicide risk. And that's it. We ended a little bit over our schedule. We got 5 minutes, so there is time for questions, and I will, as our references, and that's it. Thank you for your attention. It's been really great here. It's been great to listen to Dr. Frierson and get a lot of pearls from him, I got to say. So thank you for your time. Yeah, and anybody have any questions?
I have one question, and my question is there any link between genetics and depression? And if there is a link, then how it does affect the treatment regimen?
Treatment between, anxiety and depression?
Is there any link between genetics and depression? And if there is, then how does it affect the treatment regimen?
I'm not understanding what's the what are you saying? What's the link with depression? I'm having a hard time, I guess, understanding the audio.
Well, I'm sorry for that. I was just curious if there is any link between genetics and depression, and if there is a link, then how does it affect the?
Yeah, Xanatex. I'm hearing the word Xanatex. I can't make out.
Genetics.
Genetics. Thank you. Okay, I can't hear. I'm so sorry. You want to take that one, Dr. Frierson? I mean, Genetics and depression. Yes, it definitely runs in families and it's inherited. And we do have polymorphisms that are identified that increase risk for people who have depression. Certainly, bipolar disorder runs in families, and we know that mood disorders it probably is inherited as diabetes and hypertension and the tendency to have those kind of problems are. So, yeah, and then of course there's a genetic testing for the way people metabolize antidepressants, and we do use gene testing as a way of addressing people who have treatment resistance. And so there's some there's a purpose in doing that. But as far as choosing your antidepressant, that's a great question. Sorry I couldn't hear it.
No, you are good. Thank you.
Okay. Yeah. Are there any other questions? I had a question. So you mentioned, Dr. Frierson, that pseudodementia and depression and pseudodementia, and I wanted to make a comment. I was aware that if you do, though, have the presentation of pseudodementia, that some have said that that's an increased risk for developing actual dementia later on.
Yes.
Is that true?
Yes.
Okay. So that's something I was thinking about that when you gave your presentation. So, all right. Well, if there aren't any other questions, I guess we're at the end of the time. Thank you very much.
Thank you for your time.
Thank you, Dr. Stewart.
Okay.
Thank you for the presentation.
Thank you.
Mhm.